So what is okay, so this is the continuation of the burns and ARDS station. So here we are going, we have already done with the burn part, and now this is the second video. We will do the ARDS part. So acute respiratory failure or acute respiratory distress syndrome is acute respiratory failure, diffuse inflammatory form of lung injury, which is non-cardiogenic, origin, characterized by hypoxemia, resistant hypoxemia. Resistant, this is resistant hypoxemia, means it is not corrected with the high flow oxygen. Sorry. Decreased lung compliance, diffuse pulmonary infiltrate on chest x-ray, normal pulmonary artery wedge pressure less than 18 millimeter of Hg. In cardiogenic pulmonary edema, it will be greater than 18 millimeter of Hg. So this is the difference. So partial pressure of oxygen, FiO2 less than 26.6 kilopascal, less than 200 millimeter of Hg. What is Carico index? So Carico index is the okay, so these are the chest x-ray. You can have this in station. Okay, so what is Carico index? So the ratio of the partial pressure of oxygen, arterial oxygen, and the fraction of inspired air, oxygen, sometimes called the Carico index, is a comparison between the oxygen level in the blood and the oxygen concentration that is breathed. This helps to determine the degree of any problems with how the lung transfer oxygen to the blood. So this helps us to determine the degree of any problems with how this helps to determine the degree of any problems with how the lungs transfer oxygen to the blood. So what is pathophysiology of ARDS? Two phases are recognized in acute lung injury or acute respiratory distress syndrome. The acute phase and a later reparative phase. So we have the acute phase is characterized by the widespread destruction of the capillary endothelium, extravasation of protein-rich fluid and interstitial edema, migration of neutrophils, and extensive release of cytokines. The alveolar basement membrane is also damaged, and the fluid seeps into the air spaces, stiffening the lungs and causing ventilation perfusion mismatch. A later reparative phase is characterized by the fibroproliferation and organization of the lung tissue, and if resolution does not occur, disordered collagen deposition occurs, leading to extensive lung scarring and fibrosis. So what happens actually, that first we have the acute phase. So whenever there is injury, for example burn injury or some disseminated sepsis or any other trauma or acute pancreatitis, so what happens, that there is injury, widespread injury to the or the parenchymal injury to the lungs, which also destroy the capillary endothelium. So there is permeability. So the capillaries leak into the alveoli or the air spaces. A protein-rich fluid and interstitial edema occurs, and then we have the migration of neutrophils, and they cause extensive release of cytokines and generate a very high inflammatory condition. So the alveolar basement membrane is damaged, and also fluid goes into the alveoli as well, into the interstitial spaces and into the alveoli as well. So they stiffen the lung, and the lung cannot there is inability of oxygenation of the hemoglobin in the blood, so the lung cannot oxygenate, and so we call it a stiffened lungs and ventilation perfusion mismatch. And later on, when there is proliferation and organization of the lung tissue, for example, there is the recovery phase of the lung tissue, so a lot of disorder collagen deposition occurs, and so it leads to fibrosis and extensive scarring of the lung. So here they also diagrammatically shows that trauma, infection, chronic disease, anything which hits the human body, and so blood vessels filled with activated immune cells, inflammatory mediators, and they leak into the edema fluid thick. So the type 2 pneumocytes, type 1 pneumocytes, and we have the macrophages and neutrophils, and they produce cytokines and creates inflammation. So the epithelial damage occurs here. Okay, so fluid leaks into the interstitial fluids as well and into the alveoli. What are the causes or conditions associated with the development of acute respiratory distress syndrome? So infection, sepsis. So you have to remember the red ones. So sepsis, gastric aspiration, burns, and DIC, disseminated intravascular coagulation, and pancreatitis. So infection, diffuse pulmonary infiltrated viral mycoplasma and pneumocystis pneumoniae, miliary tuberculosis, gastric aspiration. So these are infection. Chemicals, heroin or methadone overdose, acetyl salicylic acid, barbiturate overdose, paraquat, inhaled irritant, oxygen toxicity, smoke, irritant gases, and chemicals, hematological condition, for example, trolley, transfusion associated lung injury, disseminated intravascular coagulation, DIC, cardiopulmonary bypass, pancreatitis, hypersensitivity reaction, for example, organic solvents, drugs, physical injury, mechanical trauma, including head injuries, pulmonary contusions, near drowning, fractures with fat embolism, burns, ionizing radiations. So all these. What is Berlin criteria? The new Berlin definition of ARD is categorized as being mild, moderate, or severe. So mild is 200. So these are categorized according to the partial pressure of oxygen, or the partial pressure in the blood, and the partial pressure of oxygen in the inspired air. So if mild 200 to 300, this ratio is partial pressure of oxygen if iuto is 200 to 300, so it's mild. Mortality will be 27% if it's moderate. 100 to 200, it's moderate, and 32% mortality. And it is if it's less than 100, it's severe. So 200 to 300, then 100 to 200, and then less than 100. 27%, 32%, 45%. This is the Berlin definition of Berlin criteria. This is Berlin criteria. So how will you manage cases of ADH? How will you manage a case of ADH? So we have how will you manage the case of sorry, not ADH, sorry. How will you manage a case of ARDS? Management of ARDS. I will manage the patient according to CQRS protocol in ABC manner. Admit to ITU, give supportive therapy, and treat the underlying cause. Respiratory support. First, treat the cause, and the supportive treatment, for example, the respiratory support, steroids, sepsis 6 protocol, and hemodynamic management, other supportive care. So these are the management of ARDS. We will come later to this. We'll discuss this in detail. What are the long-term sequelae of ARDS? So impaired gas exchange with the refractory hypoxemia or resistant hypoxemia. So weak ventilation perfusion mismatch, physiological shunting, decreased lung compliance, stiff, poorly or non-irritated regions of lung, pulmonary hypertension will develop. Okay, so we will discuss now this in detail. You won't have time so much that they will ask you a lot of things, but you can say that I have to go according to CQRS protocol ABC manner. So in airway breathing, I can do respiratory support, for example, moderate positive and expiratory pressure, PEP, positive and expiratory pressure. So these will keep the alveoli open in expiration as well. So 5 to 15 centimeter of H2O to prevent premature alveolar closure. Although PIP helps with oxygenation, it does so at the expense of cardiac output. In ARDS, ventilation should be low pressure and high flow rate to avoid ventilation associated lung injury barotrauma. So give them low pressure but high flow. And prone position. This has been found to significantly improve oxygenation up to 65%. This will do distribution of secretion and prevent basal atelectasis. So prone position is very important. So moderate positive end expiratory pressure PEP and prone position, and then high frequency oscillation, this lung protective mode of ventilation. So it is a high frequency oscillation, this is a mode of ventilation. So this is lung protective mode of ventilation, include low positive pressure together with the high respiratory rates. It high frequency, high respiratory rate, it prevents ventilator associated lung injury because the pressure is low. Inverse ratio ventilation, and then we have extracorporeal membrane oxygenation ECMO can be used for profound refractory hypoxemia. No significant advantage has been identified, although its role in combination therapy is under investigation. Major bleeding is the potential complication. So steroids, low dose steroids are associated with improved mortality and morbidity outcome. Sepsis 6, use sepsis 6 identify organism through the culture and treat accordingly, give antibiotic. If clinically septic but no organism cultured, use empirical broad spectrum antibiotics but avoid nephrotoxic antibiotics. Hemodynamic management, fluid should be replaced with but with care not to overload. Assessment may be made by measuring blood pressure, urine output. Final assessment may be necessary using Swan-Ganz catheter to measure the pulmonary capillary wedge pressure. If you overload the patient, you will further deteriorate the condition by inducing the pulmonary edema. So that's why Swan-Ganz catheter measurement is important. If there is evidence of circulatory fluid despite adequate hydration, such as fall in cardiac output or urine output, then consider low dose dopamines as renal arterial dilator. So 0.5 to 5, this is the dose of renal dose of dopamine. So give it and dopamine for its positive inotropic action. Dobutamine, it will improve heart contractility. If there is fluid overload, consider furosemide 40 to 120 mg per 24-hour IV. Other supportive cares are nutritional support. Feeding is better than parenteral feeding. Venous thromboembolism prevention with low molecular weight heparin, and gastric ulcer prevention with prophylactic medication, H2 blockers or PPIs. So this is all about the burn and ARDS station. This was the second video.